going to listen on this side as well. Still have in my ears. I know that in case some of you are wondering. And so what I should hear is nothing. Normal is nothing. But if there is some kind of buildup or plaque or something in there, I might hear a swishing or kind of a whistling sound. That's resistance as that blood goes through those, okay? Everything there looks good. Rebecca, as well? Yeah, and it's called a bruit if you do hear it. So when you chart this, you would chart that you have carotids or arteries, or just carotids +2 without the S with a line over it. Bruit's noted bilaterally. Okay? Then I'm going to come down, and if we weren't in the middle of class with 40 students looking at her, I would have her lift her shirt, and then I would observe her chest. I would be looking, making sure that her chest rises and falls equally bilaterally. I would also look at her chest to see if she has maybe any scars, any moles, any petechiae, anything that would be abnormal. I would note if she had multiple moles on her chest. Maybe she had 10. I would say multiple moles noted on chest, ranging from 1 centimeter up, half a centimeter to 1 centimeter or something like that. Maybe, and call them brown moles or brown colored moles. So if you then come in as a nurse, you would be able to, at reading the chart, know what you're going to see in your chest when she comes in, right? And then if she had any kind of scars, like she had open heart surgery, then I would measure it. And I showed them a little technique that I had where I've marked on my stethoscope at a beginning, then 5, 10, and then go up to 15 centimeters. So I don't always have, I don't have a tool in, I have this on my stethoscope that I can actually measure with, okay? Once I do that, then I'm going to palpate her chest, and I would do a breast exam. I would also note, just by inspection, if she had any drainage from her nipples, if I could see any kind of lumps or bumps, any kind of scarring or whatever. And then I would also note with her, with women, one breast is usually larger than another. That's a normal thing to see. And men, I look at their chest and I make sure that there's no drainage from men as well as women's nipples, which is an indication possibly of breast cancer. And also hair distribution. Hopefully, mostly women don't have that, but men do as well. And so then once I look and I've done my inspection, now I'm going to palpate. And so I would be doing a breast exam on Rebecca. I would start with her nipples and work outward and massage around. I would have her lift her arm up over her head and be able to go around, do this, and then palpate all the way down into her arm and axillary area as well, okay? Her limbs as well. If she had a mastectomy, I would describe what I see there as far as the healing process. If it's an old healed scar, I would identify the size of it, the color of it, because sometimes with radiation in that, you're going to see tissue that is purple or red or whatever scarring. And then I would note, make sure that I palpate in those areas beside it. Just because they've had a mastectomy doesn't mean you're not going to still assess that area and assess the limbs, because they can have cancer return, breast cancer return as well. So once I've done that, I also am going to palpate the chest all over besides just the breast and make sure that there is, so I might find palpating up here on the left, I might find what do you think? A pacemaker up here or something. So I'd identify that, and that would be in my notes what I found as well. Okay? Then, now I'm going to start my cardiac assessment. I start my cardiac first because once they start breathing in and out, I'm going to raise their heart rate up. So I do cardiac first. And what I'm going to assess on Rebecca are the 5 cardiac landmarks, which are your aortic, which is on the right side. I'm going to have to palpate for her and find her second intercostal space, her right sternal borders, where I'm going to set my stethoscope here using the valve, and I'm going to listen for S1, S2, which is lambda, 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 right? Once I've identified S1, S2, I'm going to palpate. Just don't jump over with your stethoscope. Palpate for your second intercostal space on the left-hand side, left sternal border, and this is your pulmonic. I'm going to go down to the third intercostal space. This is your Erb's point. I am going to listen for S1, S2. I'm going to go down to the fourth intercostal space, my tricuspid area. I'm going to listen again for S1, S2. Then I'm going to go down to the 5th intercostal space. I'm going to go mid-clavicle and below the nipple line. And there I will find my apical pulse. And if you have a woman, you're going to have to lift up the breast. And breasts vary. Even in men, you may have to lift up the breast in some men. And you're going to listen here, and you're going to listen for a full minute. The first 30 seconds I told you, I usually count. If I don't hear, if it's just normal, lump-da, 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 then I take that count times 2. If I'm hearing other things, then I'm going to count the whole minute. But I'm noting as I'm listening too, am I hearing skip beats? What am I hearing? Okay? So once I listen for a full minute, then when I'm done, that's